Welcome to the Mesothelioma Health Ask a Nurse interview session. We're privileged to be talking to a doctor and two nurses with mesothelioma experience. Lisa Hyde-Barrett, who has been a thoracic surgery nurse for nearly 25 years and has had the privilege of caring for countless mesothelioma patients over the years, offers key medical information to the readers. Ellie Erickson has been working in the surgical intensive care unit at Brigham and Women's Hospital since 1985. Before then, she worked in the cardiothoracic ICU and the ICU float pool. She earned her diploma in nursing from the Mount Auburn Hospital School of Nursing in 1978 and earned her BSN from Worcester State College in 1982. Dr. De Silva at Loyola University Medical Center and professor of surgery at the Stritch School of Medicine in Chicago. He is the co-director of the lung cancer program and the director of the International Midwestern Mesothelioma Program, Cardinal Bernardines Cancer Center. So we'd like to start off by first asking you, Dr. De Silva, what program you're currently working on.
So my program is rather a comprehensive program. We have both chest, thoracic, or pleural mesothelioma, as well as abdominal mesothelioma, under a larger umbrella that we call regional therapy treatment for mesothelioma. Regional therapy really means heated chemotherapy applied to both the chest cavity, abdominal cavity, with another surgeon by the name Pappas. He's the general surgeon. I'm the thoracic surgeon in the program. To our knowledge, it's probably the first program to be so comprehensive mesothelioma care in the Midwest. And we're very proud of it because many programs have thoracic, others have abdominal, but most of the programs do not have a purely thoracic or abdominal combined. So we're happy about that, and that's what we're working on creating, which we heard before, a team approach. So we have a multidisciplinary clinic with medical oncologists, radiation oncologists, thoracic radiologists. I'm afraid to say most of them are seasoned. They're very experienced radiologists, which is so important in the detection of mesothelioma, radiographically speaking. We also have a dietitian. We have two nurses who help us to navigate the system. So we're beginning to put all that team together. The chemotherapy perfusion part of it, it's been already in place even before I got here by Dr. Pappas. And they use the same system that I used at the Brigham when I was at the Brigham. So for me, really, it's the same procedure. We're just creating and uniting, putting together those two areas, the abdominal and the thoracic, together under one umbrella. So we're very happy with that program.
Thank you for that. I guess the next thing we'll do, we'll jump right in, and whoever wants to answer this can take it away. The first question we have is, how is mesothelioma diagnosed?
It's a very good question. Most of the patients, they present with what we call either a dry cough that's caused by a pleural effusion or shortness of breath. They just get short of breath because the effusion is pushing on the lung. Effusion is water around the lung, right? So for those who are not clear what effusion means, it's just water around the lung pushing onto the lung. So most of the patients present with that. They get treated for a while, it doesn't go away, and when they represent a few months later, it may be too advanced of stage. So for us, the most important diagnosis is a very synced into the mesothelioma clinician. What I mean by that is someone who has a high index of suspicion. Something doesn't look right for pleural effusion. The patient's too young, or there's no lung masses, or something is not really clear why the patient has an effusion. Should pursue aggressive diagnosis. And most of the places, they do let's say a thoracentesis, a drainage with a needle, negative. Well, we know that 50% of the effusions will be negative anyways. So we recommend more aggressive therapy approach, diagnostic approach, such as a biopsy, a VETSI, a fluoroscopy, which is a camera into the space and then biopsy it. So the really clue for it is patient presents with sort of not clear reason why they have an effusion. And you should jump at it instead of saying, well, it's a cold or it's a pneumonia that's resolving. Pursue further diagnostic modality.
Do you plan on doing the abdominal and the thoracic together, or just following the patient, or how many cross over?
So what we're planning to do is, if they come in predominantly with abdominal disease, then we'll take care of the abdominal disease first, and then follow the patients and see if anything were to develop in the chest. On the other hand, and vice versa, if they present with chest disease predominantly, then we'll do the chest first and follow them, knowing that it's a percentage of patients that will present with abdominal metastasis or spread through the abdomen, and then treat them when that happens. So by having the program set up so that we can see the patients together, we keep a close eye, myself from the chest point of view and Dr. Pappas from the abdominal point of view, both looking at the scans very closely. Yeah. And I think that's the best for the patient, because I'm not an abdominal surgeon. I've been trained as a general surgeon, but that's all he does is abdominal cancer surgery. So it's more accurate at diagnosing cancer than I am in the abdominal, and vice versa the chest. So we'll do the chest first if the disease is predominantly in the chest, or do the abdomen first if the disease is predominantly in the abdomen.
All right, thank you. The next question that we have is, can malignant mesothelioma be diagnosed early?
So, doctor, can you hear us? Hello? Should we continue?
I think so.
Yeah.
Okay.
Until he comes back, Lisa and Ellie can guide these questions. Absolutely. So I'll re-ask it. It was, can malignant mesothelioma be diagnosed early?
I think malignant mesothelioma can be diagnosed early if you have known asbestos exposure. Recently, we took care of a woman who had mesothelioma, and she had her father had passed away from mesothelioma. Her biopsy came back positive. She has 3 other sisters. They all got tested. I think 2 of the 3 sisters were diagnosed early disease. So when you have a family history, it's easy to kind of watch and screen. Oftentimes it's a difficult diagnosis if it's just one person, like Dr. Silva said, if you're young or, something just seems astray. But if there's any sort of family history, I think that's a big red flag. Ellie?
Yeah, the exposure to asbestos too is proven. That and the exposure could be anywhere from 20 to 50 years ago. So you really have to kind of think about it. And and I think another point is Memorial Day was yesterday. A third of all meso patients diagnosed in the United States are veterans, and that's they're tracing that back to the exposure to asbestos on the ships and all that. So I think I don't think you can. There's actually a test that you can say, okay, I'm going to get an early test for mesothelioma. It's just a lot of warning signs and family history, like Lisa was saying, and like Dr. Silva was saying, when something doesn't make sense, that's usually, that can be the reason. So, but there is no per se, test to to say, okay, you're going to get mesothelioma in 20 years, 30 years, 40 years.
All right, so going along with that, I guess, what kind of signs and symptoms should family members and people be looking for?
Well, pneumonia. A lot of times, people are diagnosed with pneumonia and they don't get better. We've also noticed it seems like some people, like get injured, and then like they might fall or play tennis. We've had a couple of people that were playing tennis or doing something, and they would fall and end up with fractured ribs and just never got better. So that's the symptoms, like Dr. De Silva was saying. It's like shortness of breath, pneumonias that don't get better, pain. Sometimes it's a dry cough.
Yeah.
And effusions, and
breath.
Yeah, and just don't feel right. Some people just don't feel right, and pain sometimes, and sometimes not. Sometimes people can present with pain, and sometimes people say they didn't know they had anything wrong with them except their chest X-ray was, there was something wrong with their chest X-ray, and that they also, kept having pneumonias and it wouldn't go away.
Thank you. So next, I guess, what is the typical treatment then for mesothelioma?
So,
go ahead.
Often the treatment is that you'll go to your primary care physicians with, like Ellie said, chest pain, back pain, shortness of breath, dry cough. You might get a chest X-ray, like Dr. De Silva spoke about. There might be a pleural effusion or water around the lung. They might drain it. 50% might come back negative, but it reaccumulates, and that kind of raises a red flag, and then they might have to go for a biopsy. And again, sometimes those biopsies come back negative, but usually they're followed with CT and MRIs, and once they're diagnosed, it's they have to figure out how advanced the mesothelioma is. Is it gone into the lymph nodes? Does it, and that's through a small incision through your right in your chest, and they stick a scope in. It's a very quick procedure under general anesthesia where they check to see if the lymph nodes have been involved. If they have been involved, then they offer chemotherapy first to shrink back the tumor, and then they would opt to take you to the OR and see if they can remove the tumor from your lung, maybe a pleurectomy or an extrapleural pneumonectomy. And again, there are, everybody's treated differently, just like everybody has different fingerprints. Sometimes you take them to the OR and you think you're going to do one certain sort of procedure, and it's a different game plan once you get in there. So you get chemo, or maybe you don't get chemo, and then you go to the OR and you can become an operative, and then you have to recover from that, and sometimes it's followed with chemo or radiation as well. It really does depend upon how advanced the disease is and what other kind of past medical history you have. Do you have a healthy heart? Do you have other comorbidities that go along with it? So each person is treated very individualized. It's not like everybody who has mesothelioma is going to get this procedure. It's very individualized according to what your needs are and what obstacles that you'll have to overcome.
Thank you.
So the question, the typical treatment, and as like Lisa was saying, in this day and age, there really isn't typical treatment. Everyone is treated differently. A lot of it also depends on your functional status, which is, functional status is how, can you take care of yourself? Can you participate in care? Are you able to, cough and deep breathe? Are you able to ambulate? Are you able to, assist in your treatments? So maybe, when people say typical treatment for meso, that's why you really need to go to see a specialist like Dr. De Silva or many of the ones that are around the country, because there's always something new happening with it, and it's not stagnant. It's not you can't. 2 years ago treatment might not be what they're doing right now. That's again, there's a lot of times people get diagnosed and they don't go to a meso center, and you're not doing yourself any favors by not going, because especially in the United States, there's enough of them around. There's enough professionals that are dedicating to their life, and they are making gains in this, so that you really should seek out somebody like a Dr. De Silva or a center. Don't you think, Lisa?
I agree, yes. I think going to a specialist is key.
Yeah.
Once you've been diagnosed, you want to find somebody who is very well versed in this disease process.
Yeah, and like we were saying earlier, it's also a team. You want a whole team that's, this is what they do. This is what they're functioning. This is what they're focusing on. This is what, they're up on the newest things, and they know the clinical trials, and they know, what might work for you. Whereas someone, a primary care physician who might just see it once or twice in their career and is relying on, the latest published data, might not know that, there are clinical trials, through no fault of their own. Whereas, the centers are much more specific and much more, oh, there he is.
Hello.
Hi.
Hi, Dr. De Silva.
I'm back. I lost my connection as I drove in. So we left at the early diagnosis, right?
Yeah. Yeah. So.
Okay. So really, is for us the most important thing is staging. As we all know, there are 4 stages for mesothelioma: 1, 2, 3, and 4 stages. So stage 1 and stage 2 are considered early stage, and really, unfortunately, most of the patients, when they show up with advanced stage. What's important is early diagnosis. So you have to have a clinician or a physician or family practitioner, whoever it is that's seeing that patient early in the game, to be more invasive, more assertive what it is that he wants to be done. A lot of times physicians are concerned that doing invasive procedures will add to the patient pain and suffering, which is not really true. We can do a biopsy today in an outpatient setting, same day, in and out of the hospital, minimal pain, but have really good tissue diagnosis. And early diagnosis is the best treatment. That's what I tell. When it gets to mesothelioma, early diagnosis is the best treatment, and that followed by multimodality therapy in early stage. But when they show up with advanced stage disease, 3 and 4, then it's more challenging.
So I guess then my next question would be, how can one ensure early diagnosis?
Right, so you really have to be, patients shouldn't take a no for an answer. That's where I think the one point that I try to make. I go around the state in Illinois giving lectures about mesothelioma, and I tell patients and I tell physicians, don't take no for an answer. If you do a puncture and a drainage of fluid and the result is negative, but the pleural effusion doesn't go away, don't accept that as being negative. Then you have to step up your procedure, either by a fluoroscopy or by a CT guided needle biopsy, ultrasound guided needle biopsy. You need to start invading the patient. Yes, there's more pain and suffering. It's an invasive procedure, but the price is much better if you don't. I think as soon as you get something suspicious and the diagnosis is negative, but the effusion doesn't go away, don't take that as a no answer. Just pursue other invasive procedures.
Thank you. I guess the next thing that we would be wondering is what steps can one take to receive the best treatment? And if this is something that we talked about a little bit while you were gone, we talked about getting a good specialized mesothelioma team, but in addition to getting a specialized team, what other steps can one take?
That's a very good question. So I think today people are more educated, and the information is easily accessible on the internet. So I think patients need to search for centers that have been treated in mesothelioma, or centers that are engaged in a multi-modality, multi-specialty treatment. What do I mean by that? Well, I'll give a classic example. If you come to Chicago, for one reason or the other, it's not really surgically driven mesothelioma treatment. What I mean by that? Most of the academic centers will not be aggressive in the surgery end. Therefore, you're more inclined to get chemotherapy as probably the only therapy than if you were to another center in which you can get chemo, surgery, and the chemo radiation following it. So patients need to say, okay, if there is a doctor in Maryland who has this trial and it sounds like a great idea, but he's not talking about anything else about the trial, I'll say, wait a minute, everybody's telling me that, and it's written in the literature and published, that the best therapy is multi-modality therapy, chemo, radiation, and surgery. If the best results are with combined therapy, why should I just go and get the latest and the sexiest therapy and no one's talking about the other modalities of therapy? It's just because they don't have anything else? Just because there's other interests behind that trial? So I say this to the patients. Look for the best place to get treated, and that has to be a multi-modality center in which they offer you all the subspecialties.
Thank you. How about Ellie and Lisa? Any thoughts on that?
He's right. He's absolutely right. What, I guess, Dr. De Silva, what do you see for about intraoperative chemo? Do you think that's the future totally, or what do you think?
You know, I don't think that's the future. That is the present.
Yeah.
In the future, we just acquired a mind-boggling intraoperative radiation therapy. So now we have a radiation machine that will open the chest or abdominal cavity, and we write in a protocol with our radiation oncologist. So we'll do the surgery, whatever we think it's too bulky or too invasive, question mark about the margins or whatever. We're going to bring the probe into the chest and just deliver local radiation. Never been done before. We're very excited with that. So,
is that a clinical trial?
Well, but then it's within a protocol. So what I'm saying is chemotherapy still is heated chemotherapy. For me, from my point of view, it still is the best result for what we call local control after surgery, not in place of surgery. In other words, if you open the chest, dump chemotherapy in there, don't take out the tumor, I'm afraid nothing's going to change. The heated chemotherapy is really to control what's left around that we can't see.
Mm-hmm.
And if there's question in margins or depth of penetration, because the chemotherapy has a depth in which it would stop working, not radiation. Radiation can bust through it. So it may be that the future will be intraoperative radiation. Maybe the future will be something different, immunotherapy. But as it stands now, the present, I think it's surgery, chemotherapy, and intraoperative chemotherapy.
Hmm. Now, the intraop radiation therapy, you do it intraop, you follow it up later? Like you...
So the protocol is being written right now. And then again, we're very excited with this because we've got the machine and we're going to start with lung, and then mesothelioma is going to be next to it. So we're writing two protocols, one for lung.
Wow.
So the whole idea is if you have lung cancer, but we really can't take cancer out, can we remove part of it and just buzz it with radiation? So when we wrote the protocol, I said, why can't we do this for mesothelioma? Has anyone done it for mesothelioma? And we looked up and no one has done it. So we're very excited to be probably the first program to offer that. Now, that's just adjunct to everything else that we're going to be doing.
Yeah. Wow. So it's gone. I think one of the, talking to patients and everything, one of the things, I think a lot of people have the impression that it's cisplatin and, cisplatin, that's chemotherapy.
Well, carboplatin, right.
Yeah.
So So within a protocol, I mean, this cisplatin-based chemotherapy, we're just reviewing a book chapter that we wrote. It's coming out next year about that. So the cisplatin-based, it works good for everybody.
Mm-hmm.
So it's not ideal drug, but it's been time and time over and over again proven to be a safe drug, has good penetration, good killing of the cells. So what we've done is add different drugs to the cisplatin base. So the cisplatin will be the basement of your house, you know, the foundation, because it really works across the border for cancer. Then on top of that foundation, built with different blocks of chemotherapy. So Genzar is one of them. Alimta is something that we're looking to doing intraop. No one is doing it. If you look at most of the research done in that area, really triple chemotherapy would be ideal. But the best results for cancer in general, across the border, whether it's GI, lung, mesothelioma, is with triplet therapy. So it would be carbon-based or carbotoxin-based chemotherapy, followed by 2 other drugs on top of it.
Wow.
Impressive.
So that's what we were saying. There's so much going on that you have to, you know,
Right.
give yourself a chance.
That's right. So, and there's immunotherapy, target therapy. I want to make a point that patients really, and patients advocates really need to understand that most of the trials, they are trials. They are not they're not to be used in place of or to replace the current therapy that we know it works, which is chemo, surgery plus chemoradiation. Because if you start replacing, especially early stage disease, if you start replacing the multimodality therapy that we know works by a single trial, then you're setting yourself up for, I'm not going to be able to take this call, I guess. Someone from Boston's calling me. I wonder who that is.
Not me.
Imagine, I can't even pronounce his name because it's one of those foreign names. Anyway, so joking apart, all I'm saying is you shouldn't be lured into doing a trial. A trial. A patient should go to a trial after the standard of care has been applied to that patient. So a lot of patients come and ask questions. Well, you know, I want to see you, but you said surgery, chemo, but Dr. X, Y, and Z in California has this new drug. It's a trial. You know, I said, well, it's not the standard therapy. I would not suggest you do that. If you want to pursue that, it's fine. It's your life. It's your choice. As a physician, surgeon, I really can't suggest that. You've got to go through the steps. If those treatments fail, which, as we all know, eventually they fail because there's disease progression and so forth and so on, then you go into a trial because there's nothing else. Now, if you go to a trial, you may have burned bridges. Now, the trial doctors are brilliant doctors, and they want to make sure that their trial works really well, and we support them. Of course, we have trials here too for lung cancer, not for meso at this point, but for lung cancer. And they put barriers in which to say if the patient gets X, Y, and Z, can't qualify for my trial. They almost want to replace everything else for the trial. I think the trial is reserved for those patients in which multimodality therapy is not really indicated, or the multimodality therapy has been applied and failed, and you're looking at early recurrence. And then, yes, I think you should go into a trial.
Thank you. I think a common question that our viewers would have is what do I need to do to participate in a clinical trial? Right.
So my point of view is there's a very strict, every trial has a very strict, very narrow window through which you can squeeze in. So I think the first thing you need to do is the type of mesothelioma you have. Cellular type. Is that epithelioid? Is that mixed? Sarcomatoid. Those are like the number one information the patient needs to know. To say I have mesothelioma, but they really can't tell what the diagnosis is, no, it shouldn't be in a trial. You've got to have the diagnosis. That's number one. And that may require surgery. You know, that may require invasive procedures, I was telling you before. So that's number one. Number two is the patient needs to be aware that there's other treatment options. If the patient has been on a trial, usually does not prevent the patient to go into surgery multimodality therapy. We still take those patients. But if you're going to go on a trial, usually they don't want you to have the multimodality therapy. They want it out of the equation. So if the patient's going to go on a trial, they have to know their stage, their type of cell, right? Mesothelioma cell. Stage they are in, is that early versus late stage, stage 1 or 2 early, stage 3 or 4 late. But most importantly, we need to see the patient, see if they can't tolerate surgery and multimodality. A lot of times they can't. And then a trial, it's different.
Thank you.
How are you making progress with sarcomatoid? I guess that's.
With what? I'm sorry.
Sarcomatoid?
That's a very good question. I did a patient, my very first patient here in Chicago with sarcomatoid mesothelioma, which again, he had 2 biopsies in an outside hospital. First a needle biopsy, then a core biopsy, then a VATS biopsy. They're all negative. They couldn't tell, necrotic tissue, blah, blah, blah. He came to me and said, I will not take a no for an answer until life is on the line. We have to do an open biopsy. I'm sorry to tell you that. You gotta go to the OR. You gotta have surgery. But I'm not taking that for an answer. Looks like meso, smells like meso, runs like meso, has all the colors of meso. You have meso until proven otherwise, and it was sarcomatoid, and it was high-grade sarcomatoid, and that's why it's so hard to treat sarcomatoid mesothelioma, because most of the cells, they are so aggressive that they will not even eat the carbotaxol. So we did surgery, and now he's going to get radiation therapy. So the progress, again, is aggressive surgery with sarcomatoid if you can, all the way in. For chemotherapy, we do have, interesting enough, we do have here, which I'm part of it, and we're just actually named a co-director, something, a sarcomatoid clinic that we see Thursday afternoon.
Wow.
So, right, I guess, anyways, they heard I do sarcomatoid surgery, they want me to be part of that. But, and I go to their clinic, to their meetings. Again, it's another different meetings, it's multimodality. And it's kind of disheartening to see that they really are against the wall. They don't have a lot of chemotherapy options. They do have some. And the way we play this, if they give chemotherapy 2 rounds, if you see regression, I charge him. There's progression, then I'll step back, and then they try to figure out what's going on. But to answer your question, Allie, there really isn't, at this point, something that will jump us and say, oh, wow, this is a miracle drug. There isn't.
Oh, boy. Now, what about the new drugs, the new biologics? Are you having?
Well, yeah. So those are trials. That's going to take a while to really pan out. I think the work that Rafael Bueno is doing at the Brigham is it's leading the ground. He's breaking ground. It's a few years from now. But I have to tell you that as close as it's ever going to get to determine the genetic material mutations, what we call epigenetics. Someone said, how much asbestos do I have to get mesothelioma? That's called an epigenetic factor, something that changes your DNA after you're born, like a grown-up person. And no one is doing more work on that than Rafael Bueno, but he's still 5 or 6 years away from actually getting someplace. So when I learned about that, and he and I talked about that several times, actually the last 3 months for other reasons that we've been in contact, he and I said, you know, Rafael, I think it's still, that's great, it's the right direction, but we're not there yet. And he said, yeah, we're probably 5 to 6 years out before we come up with something that will make a difference in the mesothelioma world. Mm. But there's progress, though. Yeah. There's a lot of progress.
Yeah, I think that's the message you got to get out.
Right. Really. So there's a couple myths about mesothelioma patient, and I learned that, and people laugh at me when I say this. But one is you got to stay positive. You got to think positive. You have to understand there's hope, and you have to understand there's very intelligent, capable, and doctors all across the country, medical oncology, radiation oncology, surgeons. They're passionate for what they do. They all are. If you get in a table and They all want more chemo, all more radiation, more surgery because we're passionate for what we do. And there's a lot of people involved with that. I was at AATS in Toronto, and the group in Toronto are very strong with radiation pre-op, followed 2 weeks later with surgery. I'm going to adopt their protocol as well. So there's people really look into this. Another friend of mine from London, I should go visit him soon. He's got a different protocol with iodine. Of all the things, iodine is scrub in the chest. It's got great results. So I'm thinking, oh my golly, this is fantastic. People really going at it, and at some point we're going to find the answer for this.
Yeah. I think you will.
You kind of touched on this in answering that last question, and I wanted to ask, how long or how often does a person need to be in contact with asbestos to have a high risk of developing mesothelioma?
Right, so that's a very good question. So there's two factors there. One is the amount of exposure, right? So if you're in a room like this closed and it's white, pale, white with asbestos, and sometimes we hear that from patients saying, I was working in the Navy and they put me down in some submarine or whatever it was, and we couldn't see each other because it's white, like snowing in there, and you know the exposure is really high. And he says, but I was there for 2 weeks. Well, it doesn't really matter. Now the second is time. So here we go. Now we have something called the epigenetics, which is something that jumps over like a saddle on a horse, right? So the horse is your DNA. The saddle is something that you put on the horse to drive it around. So the epigenetics is something that comes onto the horse and changes the direction that horse is going. So asbestos exposure, the more you have onto the horse, more chances that horse will change its direction. In other words, the more chance the cell will change its direction into cancer. That's one, the amount of asbestos. And the other is prolonged time. For example, someone says, well, really, I wasn't sure because my dad was working in it. He would bring clothes with asbestos. I would clean every weekend or so, whatever it may be, but for 15 years. So then you have that little epigenetic factor jump onto the cell, even though a small amount, throughout a long period of time until a certain amount of time, the cell changes its cycle and goes into cancer cycle. So both the exposure and time are important factors. Which one is more important? In our experience, it's exposure.
Oh.
So I say this because we saw a patient who said, I think I worked in the summertime in a camp in Australia and the bags were full of asbestos, but I was 17, I need some cash. And I did that for 3 weeks. But this is 40 years ago, 50 years ago. Yeah, but there was enough got left in there and made those cells change in a different direction.
Wow.
And that's the fascinating part of it. It's almost like a detective. You have to go back and find the reason for that.
So, Dr. De Silva, is there a ratio of people who are exposed to asbestos versus who come down with mesothelioma and who don't?
Yes, the majority of patients don't. And that is the conflicting. But if you look into lung cancer, 60%, 60, depending where you read, 60% of patients who have lung cancer never smoked. Don't even know what cigarette is. 40% smoked. But if you go around and say, of the patients who have lung cancer, present with lung cancer, what percent of them smoked? 90%. So there we go. And say, well, what's up with mesothelioma? If you go around and say, what percent of patients are exposed to asbestos got mesothelioma, the incidence is going to be lower. But if you go back to the patient who have mesothelioma and say, were you exposed to asbestos? Yes, the majority of them will be exposed to asbestos. So it crosses over. I don't know if it made sense to you what I just said. So, in other words, if you've been got 100 patients being exposed to asbestos, about 1-2% of patients who have mesothelioma. But if you say, well, forget about that, let's see all the patients who had mesothelioma around the world. What percentage of them were exposed to asbestos? 90%. Why is that important? Because that tells you that asbestos, nothing else, there are other components involved with it, but asbestos was the predominant factor to change that cell direction.
Now, are you seeing people from all over the world? You know, because it seems like, you know, this, you know, are they coming or will they come?
So right now, they're coming from Boston, which to me is all the other part of the world. No, I mean, we've got people from Canada coming down here. We have Illinois, Michigan, Wisconsin. They have what they call unions for pipe fitters and plumbers.
Yeah.
They call locals, LOCAL, locals. And so we send 51 information set to those places and trying to get people to come here, because a lot of people don't know there's a program up and running in Chicago. We do get, I mean, the idea that people, someone from Brazil was going to come and see me, and they decided to go for a trial first, which is perfectly fine. And so, yes, I mean, we open for business.
And so people from the locals, whether they're symptomatic or not, come and see you?
No, only when they're symptomatic or someone saw it. So what I'm trying to send, I send to the locals, because when the patients, when pipe fitters or plumbers get sick, they have to report their sick to the locals.
Right.
Then the locals, they don't know where to send the patients. They say, well, you know, go to Boston, go to Maryland, go to someplace else, go to Pittsburgh or Philadelphia. Now I'm telling them, you don't have to send them out. I'm in Chicago. You can send them to us.
You brought up a good point at the beginning about patients navigating the system. That's, you know, mesothelioma is a unique disease, because I think a lot of people hear about it from all the ads and all that, you know, that's on the TV, but they don't really know what to do about it. So, you know, like you speaking, you know, kind of gives it a face more than anything, you know. But can you speak a little bit about patients navigating the system? Because I don't think a lot of people know how to like get in contact with you, or you know what I mean?
Right. So we've been working. I mean, I've been here since September. Mm-hmm. You know, if you take September out, because it was one of those months, just move in, and then December was kind of another kind of down month. We've been here for about 6 months now, and I have put a lot of emphasis in contacting different local agencies, Web Connection, Cure for Meso, IMG, the study group for mesothelioma, and let them know that we exist. There's going to be a publication, I think, one of the sites for mesothelioma, and we're trying to get support from the media here in Chicago to have either TV or newspaper advertise with patients telling that they had a good experience in our program. So I think when patients go out and try to navigate, there's a lot of misinformation. Mm-hmm. So I think for the sites that you don't have the input of both nurses and doctors highly involved in treatment and care of mesothelioma, we should exclude them. Mm-hmm. The other options, go to sites where people have the most hits and ask the question, what are the places that I can go? One of the sites actually lists universities by location where you can go and get comprehensive mesothelioma care. Yeah. So that's a good site, but they don't know it, so they have to select which one's best.
Yeah, I think it must be very confusing for them.
Correct.
Yeah. Now, do you think the United States, is it the United States and Britain? Well, I don't know how aggressive Britain is, but the United States, are they leading in aggressiveness?
Yes. Yeah. So is England. England's beginning. Oh, I should say the UK, beginning to change a little.
Yeah.
Not much, but a little, and that's mainly because there's a new generations of thoracic surgeons coming up, like myself, and we have this very selected group that we exchange information across the pond, and they're beginning to get more aggressive, including in France and Belgium. Switzerland is beginning to do more. So,
Oh, well,
yeah.
that's good. And there's can you touch upon that? There's a little controversy in the meso world about the EPPs versus the pleurectomies versus, whatever.
Yes. So every patient is different. Every disease is different. To say that one treatment fits all is wrong. I mean, we do have passionate people on both sides of the screen, right? You have people passionate about EPPs, you have people passionate about pleurectomies. If you really select your patient appropriate to the disease stage with the correct treatment, it really isn't different in survival. Okay? Now, the difference comes from 2 points. One is staging. Again, the early diagnosed staging of the disease is paramount to the survival of the patients. That's number one. Number two, you can go and have an EPP and don't do well, or do a pleurectomy and don't do well. The issue there was the wrong treatment for the wrong patient. You have to tailor that. A few patients will benefit from a left extrapulmonectomy, early stage, young patients, female. No question about it, with good pulmonary function. Someone who's elderly and has got poor pulmonary function, to take the whole lung out, they might not do well. So you have to tailor your surgery. Having said that, I, for one, have been a great advocate of saying you really have to select the patients for the right operation. The results, survival, very little difference. What is different is sometimes you have early recurrence or more recurrence in the pleurectomy side. But now we know that we can go after those recurrences as well. So, I don't know if I answered your question, but we have as many patients in one arm versus the other with long survival and doing extremely well.
Yeah, which is a good message to get out there.
Right.
That there is patients surviving, but more importantly, they're doing well.
Correct.
They're living a good life, good quality of life.
Right.
And are you seeing younger patients, Dr. De Silva?
Not yet. They haven't come my way yet. I'm getting the pipe feeders and the plumbers, and when I came here, I thought pipe feeders. I thought they were extinct. I guess they are, except in Chicago.
Oh.
But I hope, in all honesty, I hope I don't see young patients.
Yeah.
We're plenty busy, and we're passionate about mesothelioma care. But mesothelioma, as we all know, it's a dreadful disease. But we have hope. We have ways to treat those patients.
All right. Yes. So that would you think that would be, that's, I think, the important message that you want to get out here, that, you're in Chicago, you're, up and running, and there is hope.
Correct. There's hope. There's very intelligent, capable, educated physicians involved in the care of the patients. We understand much more about the disease now than we did 10 years ago. We understand much more about which treatment is better for every different patient than we knew 10 years ago. I think the future for mesothelioma patients is really bright. I do not subscribe to a nihilistic approach. I don't believe in it. I don't believe even someone a fishing rod is the right treatment, although it might be for a few cases. But I don't believe in that. I don't subscribe to that. I'm one of those half full glass apple guys. So I usually tell the patient, let's go. If you're up for it. I saw an 85-year-old lady. She needs surgery. She says, am I too old for that, Sonny? I said, no, you're not. If you call me son, you're not. You're on the schedule.
Again, positive attitude always helps.
Correct.
Thank you.
Well,
Thank you.
Yeah, very good.
Any other questions, Katie?
I think that's all the questions that I had. So if there's any questions from you or Ellie, feel free to ask them. But if there are no questions, we can conclude this.
Dr. De Silva, do you have a website?
I do. What I will do for you is I will send it to you.
Perfect.
Okay.
Great.
But it's a lot. It's Loyola dot something else. I have to go back and get it, and I'll send it to you guys.
Just send it to us.
There's a website, and we're trying to create a mesothelioma website. I'm in the Loyola website, which has 2 of my interviews, including an interview about mesothelioma. And that'll be www.loyolamedicine, one word, .org, and then you have to search Silva, and that comes right up. So what I've been working with the hospital now is to create my own website within the hospital website for mesothelioma, but somehow that has become a challenge for me, believe it or not, within my own institution, but I'm used to that already.
Well, thank you.
All right.
Thank you for the opportunity.
I want to
really
thank
appreciate
all
the
of
time.
I want to thank all our nurses, Lisa and Ellie and Dr. De Silva, for taking your time to talk to us and to answer some questions that people will have. And if any viewers have any more questions, please leave comments or fill out a comment card on mesothelioma.help.org, and we can provide more resources and answers for you.
So just before I go, I also have a blog at the Loyola site. I'm going to send that to Lisa. I've been answering a lot of questions about mesothelioma and lung cancer on my blog. The month of February and March were the #1 responders to the blog. I had the highest hits in the Loyola site. And the reason for that is I just like to talk to patients, and the blog is a great way to answer the questions.
All right, great.
Well, thank you for sharing that.
Yeah, thank you.
Okay, you're welcome. And I'm sure Lisa will get all this information to you guys later.
Yeah.
Absolutely.
Lisa,
Have a wonderful night.
Have a good evening.
You too. Thank you very much.
Thank you very much.
Yeah.
Good night.
Bye. Bye.